A very good afternoon to you all, ladies and gentlemen. It's a privilege to address this seminar on behalf of ISHRE. Healthcare facilities are dedicated to the healing and caring of patients. However, the environment in these facilities can pose risks. The question is whether the air we breathe in healthcare facilities is a silent killer or it aids in healing. I give you two examples that I've chosen because they are well documented. First is in 2017, 76 patients, 76 patients and staff contracted tuberculosis at Nair Hospital in Mumbai. There was some thorough investigation and they found that it was because of contaminated air conditioning ducts and inadequate ventilation. Similarly, in 2015, 22 patients and staff, that is 2 to 22 patients and staff, contracted swine flu at KEM Hospital in Mumbai. Again, investigations revealed no prizes for grazing, contaminated air conditioning ducts, and poor ventilation. These incidents and many others show how important it is to make sure that the air conditioning in healthcare facilities provides comfort and aids the healing process. It restricts the disease to the patient and does not propagate it to the other patients and healthcare workers and visitors. So, this is the key thing about air conditioning for any healthcare facility. I'll with that start the presentation. Can you see the presentation screen?
Yes, sir.
Okay. So HVAC systems in healthcare facilities are for patients, healthcare workers, and visitors, and all should remain safe in the environment. The HVAC systems are in support of patients who are uniquely vulnerable to elevated risks of health, fire, and safety hazard. Why elevated risks? Because all of them mostly are in very low immunity conditions. And healthcare facilities vary widely in nature and complexity of services provided for injury or degree of illness of patients. And facilities could be general practitioners clinic, civic hospital or university medical centers, specialty hospitals, diagnostic centers, maternity centers, mental wellness centers, etc. So, infection sources in medical facilities, relatively high levels of pathogenic, that is, disease causing microorganisms, are generated and concentrated by infected patients or by a procedure that handles infected tissues or fluids. Surgical operations in large scale in big hospitals heightens the danger of cross contamination between patients, hospital staff, and visitors. Antibiotics are for protecting the patients. Over time, some antibiotic resistant microorganisms colonize the hospitals. Patients not carrying such microorganisms have a high risk of infection during their hospital stay. Uh, how is the hospital air different from the normal air? Let's just look at a few parameters. There is this RSPM, that is your respirable suspended particulate matter. So we have heard of PM10, PM2.5, and PM1. It's there everywhere, including in hospitals. In hospitals, especially, why it matters more is because the particulates are also something that carry the disease, because microorganisms need something to attach themselves to, and particulates are the ready media for doing that. Uh, just as an information, for there was a study in a particular hospital in USA, which they carried out all over US, not in India, all over US, and they found that for every 10 microgram per cubic meter increase in PM 2.5, they found that 4% increase in admission rates were there. So that gives you some sort of a correlation between RSPM and the chances of getting infection. Next is latex. You find the widespread use of latex in hospitals. There are less latex gloves. Then there are latex tubings, and each time a nurse or a doctor wears latex, it releases airborne latex allergens in the air. It enters the human body through mucous members and through eyes and can cause allergies. Then we have got the anesthesia, nitrous oxide, isoflurane. These are the common anesthesias. And basically, anesthesias are not very, uh, you know, they can be quite toxic and have to be, contained to only where the usage is there. And if you've seen the latest magazine, that ISHRE journal, you'll find a very good article on optimization of ventilation design for hospital post anesthesia care units. And in this, they have given so much of data how the forget about just the patients, the healthcare workers get affected by anesthesia, uh, residual anesthesia in these rooms if they are not ventilated properly. Then we have got the cold sterilants. Cold sterilants, you've got instruments, surgical instruments, and various other items that needs to be sterilized from time to time. And all are not hot sterilized. Sometimes you have to do with cold sterilants. And cold sterilants are like ETO, then H2O2 gas plasma, glutaraldehydes, and these are all very severe chemicals. And it's not possible to always contain all the fumes that come out because of these. And these fumes then also become a part of the hospital atmosphere. Then we have got, the lab chemicals. Labs, pathological labs are part of any hospital, and they use these enzymes, substrates, reagents, alcohols, formalin, and a very wide variety of chemicals. And all these vapors are also in the hospital air. And then we have got, this is something big, disinfectants and cleaning agents. Now, these are used so widely in the hospitals. All the time some cleaning is going on in order to take care of, the microorganisms. But what are these disinfectants and chemical agents? There are quaternary ammonium compounds, phenolics, paracetic acid, sodium hypochlorite. All these chemicals are, not very what shall I say, soft chemicals or something like that. They can attack people. Even the healthy people get affected by them. Let alone, these patients who are breathing it all the time. So all these kind of chemicals are there in the hospital atmosphere, which you are not likely to find in normal, normal habited areas. And now we come to things that are even more frightening, I might say. You've got microorganisms in higher densities in hospitals. There could be TB bacteria, highly infectious aerosols generated by TB patients by cough, sneeze, or by speech. Then you've got the chance of Legionella bacteria, water mist discharged from cooling towers and fountains, and then drawn into the indoor environment through outdoor air intakes. Then you could have this Staphylococcus aureus. How does this come from? Microbial aerosols generated by surgical procedures during bone uh, saws, bone drills, during orthopedic operations. These can get into the skin, blood, urine, nose of infected people. Then we have got aspergillus spores. The fungal spores come from soil, plants, animals, and dust particles and attach to the clothing of healthcare workers. Then we have got the superbugs. Antibiotics have been used very freely over the years, and some of these antibiotics, I mean, some of the bacteria, viruses, and parasites have developed a great deal of resistance to antibiotics. Some of the common ones are CRE, VRE, MRSA. Then there is as uh, pseudomonas aeruginosa, and these are, once these kind of superbugs attack any patient, really they don't have any antidote for a disease that comes following this attack. So, all in all, it is quite a, what shall I say, frightening type of atmosphere when you get into a hospital. Uh, Findings of International Nosocomial Infection Control Consortium. Basically, nosocomial infection is what you get within a month's stay of, within a month after a stay in a hospital. And there was a very elaborate study that was done. 10 participating hospitals were there in India, and 28,340 procedures during the period 2005 to 2011. Though this data appears dated, I've taken it because it is quite exhaustive and I don't have anything more contemporary. But this is quite indicative. You can see that uh, you know uh, hip prosthesis, 2.1% chance of getting nosocomial infection. What it means is one in 50 uh, of those patients who have gone through hip prosthesis would definitely get some sort of infection. Vaginal hysterostomy, it is 2.5%. Thoracic surgery, 2.8%. Limb amputation, 3%. It goes on till breast surgery, it is 8.3%. And the average is 4.2%. What 4.2% means is one in, say, 25 operations are definitely going to result in nosocomial infection. Now we talk a little bit about the human respiratory system. We have got the upper respiratory system consisting of nasal cavity, pharynx, larynx, trachea, and then you have got the lower respiratory system comprising of bronchi, bronchioles, and alveoli. And basically, the human body is a sort of filtration system. Uh, the human body has strong defenses against respiratory infection. Multiple layers of filters exist, beginning with the mouth and the windpipe. Moist surfaces with a mucus layer collect large particles and preventing their entry into the trachea and pharynx in the upper respiratory tract. In the lower respiratory tract, the bronchi and the alveoli can efficiently capture the smaller particles to varying degrees. I'm just showing you one small video. This will give you some idea. Now I'll show you just one more video, then you'll get a better idea. So that gives you some idea how our respiratory system, is aided by, the humidity. When we say 100% humidity, it's all the time it's 100% humidity. Only when, the outside humidity is lower, the humidity inside the lungs drops down. So we'll just take this same, logic forward in some of the subsequent slides. Uh, Types of airborne particles. Airborne particles can be toxic, chemicals, allergens, or infectious agents. These particles may enter the building from outside or from processes inside the building. We talked about, the bone sawing and things. These are all processes inside the building, or doing uh, your ETO or gas plasma. These are all processes inside the building. Outdoor air can contain fumes from vehicles or diesel generators. Rural areas can have pesticides or agricultural dust. Building finishes can emit hazardous dust. Then exhalations from patients can be a source of infectious agents. This is the contamination pathway. For a contamination to occur, there has to be a source having the contamination, then has to be transport mechanism to reach the susceptible site, then there has to be the contact with the susceptible site, and finally retention at the susceptible site. So all four things are needed for a contamination to take place. And uh, basically, any break in this pathway prevents contamination from taking place. So this is sum and substance of how you prevent infections. Infectious agent is the microorganism that can cause infection or disease. The infectious agent can be transmitted by tiny droplet nuclei containing microorganisms, such as measles, tuberculosis, that remain suspended in the air for a long time and can be carried over large distances by air currents. The place of entry into the susceptible host is the mucous membrane, for example, the eyes, nose, mouth, or the respiratory tract. You can see, when there's an operation, you can see the wound at the bottom. And just a moment. The wound at the bottom, and there are various places from which a surgical infection can take place. The adjacent area, the instruments which might get infected, the operating room personnel with their hands and mouth, they can emanate, infections, and the patient's adjoining skin, that also could be a possible place from which infection comes. And by using, watertight clothing or gloves or masks, uh, you try to see to it that the infection does not get delivered into the wound. Particles and microorganisms in the air. Air cleanliness for particles is well defined, is described by well defined and accepted standards. Specifying the cleanliness class of a room gives clear guidance to design, construct, and test it. Particle counting is a rapid process and gives real time results compared to testing microbial contamination. Microorganisms do not travel in the air by themselves, they are attached to particles. So, what we are trying to say in this slide is that we look at particles, how to control the particles, and as a result of that, we control the microorganisms. As per this study of NASA NHB 5340, 1 in 1000 particles with sizes more than or equal to 0.5 micron in clean room zones of ISO 5, carries 3.5 microorganisms per cubic meter of air. This is one number. Similarly, in ISO 8 is a much less clean than ISO 5. ISO 5 is what is commonly called a class 100. ISO 8 is what is commonly called class 1 lakh. So in ISO 8, of 1 in 40,000 particles with sizes greater than or equal to zero point 0.5 micron in clean zones, ISO 8, 88 microorganisms per cubic meter of air will be there. For non-classified dirty rooms, the number will be much larger. So let us look at what happens on a 1 meter square area per hour, how much deposition is going to be there. So 80 microorganisms for class 5 ISO uh, uh, class, that is your class 100. And in the case of ISO 8, 2000 microorganisms would be deposited per hour on a 1 meter square surface. For non-classified rooms, this number is going to be much higher. And we'll now just look at what happens in an open wound operation of 20 centimeter by 20 centimeter, 0.04 square meters during an operation. Consider a 6-hour operation. You'll find that using the same data, that 480 microorganisms can enter this wound in a class 8 ISO room. Whereas if you use class 5 ISO room, that is like a laminar flow with class 100 air, a similar calculation will result in only 20 microorganisms entering the wound. So basically, it's a comparison between 480 microorganisms entering the wound compared to 20 microorganisms entering the wound in a class 5 ISO, under laminar flow. So though this is not ideal, it shows that the effect of laminar flow can be very good for doing these kind of operations. The chance of infection becomes much lower. We'll just briefly look at an infection equation. Infectivity is the ability of an organism to enter, survive, and multiply in a host. Then basically, uh, what is this organism? It could be a pathogen, it could be bacteria, virus, fungus, or parasite, and how easily it enters and multiplies in a host, causing infection and potentially leading to disease. That's what matters. So you can just take the example of influenza. The infectivity of influenza virus is demonstrated by its ability to spread through respiratory droplets from an infected person's cough or sneeze, entering and replicating within the cells of a new host respiratory system. Then we have got infection occurs when there is an infectious agent in a source, a susceptible host, and most critically, a way for the agent to be transmitted from the source to the host. Here we have got an infection equation, that is dose into site into virulence into time divided by the level of host defense. Now here one of the items is virulence. So what is virulence? Virulence refers to the degree of harm or severity of disease caused by a pathogen in an infected host, measuring its ability to overcome the host's defenses, replicate, and cause damage. You can take the example of Ebola virus. The virulence of Ebola virus is demonstrated by its high mortality rate, that is almost 90%, and rapid progression from symptoms like fever and headaches to severe hemorrhaging and organ failure. So basically, if virulence is high, the chance of infection is high. Then if the time of operation, the time it takes for an operation is more, then chance of infection is more. Site, the bigger the site, more the chance of infection. Then this dose is how much is the quanta of the pathogens that are getting into the site, and divided by the level of host defense. Most of the cases, the host defense is very, very low because someone might be under medication, under low immunity levels. So if you see, if the level of host defense is very low, chance of infection is high, dose is more, site is big, virulence is more, time is more, infection rates are going to be high. The typical operations which are going to be less likely to have infection are those which have got a shorter time duration, uh, and you don't really have a handle on the virulence. Site is how small you can make the incision. For example, in endoscopy, they make very small incision, so that way you can reduce the chance of infection. So we'll come to some other concepts as well. Look at the sizes of the microorganisms. Viruses are 0.05, 0.01 micron to zero point zero 0.05 micron. Bacteria are 0.05 to 5 micron. Fungal spores and yeast are 1 micron to 100 micron. Pollen grains 10 micron to 400 micron. Uh, See, all these various pathogens can be easily filtered out. We'll come to that when we come to filters. But the fact that you have to always remember is that microorganisms are easily collected by filtration, but microorganisms can multiply in the filter, releasing dead or living byproducts. This is a point that you should never forget, that though the filters can catch hold of all these pathogens, these filters become the place where these become the breeding grounds. Viruses and bacteria normally occur in colonies or on larger particles. That's the other point you keep in mind. Requirements of filtration. Standard ASHRAE standard 170-2021 gives efficiencies of filtration together with pre-filters for different areas. And then I'll be showing you a table. As shown in the table, MERV 14 filters remove 75 to 85% particles in the range of zero point 0.3 to 1 micron. HEPA filters, earlier called MERV 17, are often specified in PE rooms, that is your positive environment rooms, preventive environment rooms, then bone marrow and organ transplant patient rooms, super specialty operation theaters. Now, let us just briefly look at the MERV chart. MERV chart is coming from ASHRAE 52.2, and you've got these MERV ratings which go from MERV 1 right up to MERV 16. You can see that there are three ranges. Range 1 is 0.3 micron to 1 micron. Range 2 is 1 micron to 3 micron. Range 3 is 3 micron to 10 micron. So if you can see, MERV 1 right up to MERV 16 can do filtration to various efficiencies for 3 to 10 micron. Whereas if you look at the range 2, that is 1 micron to 3 micron, as far as MERV 1 to 7 is concerned, they do nothing at all. MERV 8 to MERV 16 have got various degrees of efficiency. Coming to range 1, that is 0.3 micron to 1 micron, you've got MERV 11 to 16 doing various levels of efficiencies, whereas MERV 1 to 10 don't do anything at all. Now we look at another chart, that is your filtration efficiencies at MPPS. I'll tell you what MPPS is. As per ISO 29463. So MPPS stands for most penetrating particle size, around zero point 0.2 micron. And you can see this particular chart. Uh, if you look at this small chart out here, uh, the way the filters act is that there is a particular size of particle which is the most penetrating size. That means the efficiency of this of the filter for the most penetrating particle is at its lowest. So if you say that this is say around zero point 0.2 micron, and here the MPPS you can see is something like 99.95 percent. For all the sizes which are smaller than this zero point 0.2 micron and bigger than this zero point 0.2 micron, the efficiencies are better. You can see that this particular filter, which has got 99.95% efficiency at zero point 0.2 micron, it's almost heading towards 100% at 0.01 micron. That's the way the filters behave. So this is something that you need to keep at the back of your mind. Now coming to infectious droplet efficiency. Uh, Basically, we are really not interested just in micron sizes and all those things. What we are interested in is what it does in terms of efficiency towards infectious droplets that are coming out during the respiration. So, infectious droplet efficiency, that is IDE, measures a air filter's ability to capture infectious droplets, typically ranging from 1 micron to 5 micron in size, that may contain pathogens like viruses, bacteria, and fungi. The droplet size ID focuses on capturing droplets in 1 micron to 5 micron range only, which is significant for infectious disease transmission. So, if you see this particular chart, you'll find that MERV4 has got 10.5% efficiency. Going to MERV6, 16, it is 95% efficiency. HEPA filters, it is 99.9% efficiency. Just look at MERV14, it is 88% efficiency. And in all the critical areas in any hospital, such as in ICUs, you'll find that MERV14 is being recommended as the fine filter required in that area. It's not really necessary to put HEPA filters everywhere. MERV14 can do a good job. So that's about the filtration. HEPA filters are used only in certain areas, like laminar flow units or in isolation rooms. We use HEPA filters. Otherwise, all the other areas, you'll find that MER14 is good enough. So in standard 1702021, you'll find a very comprehensive list. This is just an extract which says for various types of rooms, what is the filtration that needs to be used. So this is like a prescription. You have a room, which filtration to be used in that particular room. Then we have got a recommendation on outdoor air. It is recommended to use MERV 13 or better grade of filtration for outdoor air. And then when you exhaust the air, because the air from any healthcare facility is likely to be very toxic, it is recommended that you should exhaust the air through at least a MERV 10 grade filter. And this is another important thing about any filtration in healthcare. You should always have two banks of filters. One is a pre-filter before the cooling coil, and then there should be a fine filter after the blower. This is because right up to the blower, all these are high maintenance areas, and after the filter bank two, you don't want any further chances of dust coming in during maintenance. So that's why you should always have a filter bank after the blower. So that's what it says. It is recommended to use at least two banks of filtration. One filter bank should be installed prior to the cooling coil, and the second filter stage should be installed downstream of the fan to avoid contamination from the fan drive. Now we come to air change rates. Uh, Here we are going to look at what happens when you have, more and more air changes. What is air change? Air change is, when you say it is two air changes, for example, it is how many times you are replacing the air inside the room per hour. So when you say it is two air change, it is you're changing the same air twice in an hour. So four is four times in an hour. So going right up to 50 out here. So we are trying to find out here what happens to a contamination that is introduced into the in the room. How fast it is going to dilute to 1% of its original uh, concentration. So if you have got uh, two air changes, it requires 132 minutes to come down to 1%, that is 90%, 99% removal, that is 1% of the original contamination. It is achieved in 138 minutes with two air changes per hour. So if going right up to say 12 air changes per hour, you get 23 minutes, and 50 air changes, of course, 6 minutes to come to 1% of the original concentration of the contamination. So this is the source. It is coming from CDC. It assumes perfect air mixing. That's a big assumption. Then there is an excerpt in ASHRAE standard 1702021 for various areas. This is not an exhaustive list. You can always look at the standard. You will find, all the areas they've given what should be the pressure, what should be the temperature, what should be the RH, how many air changes for outside air, how many recirculatory air changes. These are the minimum that need to be, designed for in these particular areas. Now we come to pressurization. Why pressurization? Positive pressure clean rooms. That is, if you've got a uh, positive pressure, when a patient has to be protected from airborne contamination coming from adjoining spaces, the room is kept at a higher pressure, that is with respect to the surroundings. So you know that if this area where the patient is kept is in a positive pressure, then the air from this area will go out, not the other way around. So air only exfiltrates from these rooms. Then we have got some cases where we want negative pressure, that is called containment rooms, when adjoining spaces need to be protected from potent drugs like nuclear medicines, or from patients with airborne infectious diseases. The room has to be contained. The room is kept at a lower pressure with respect to the surroundings. Air infiltrates into the room, not vice versa. So if you've got an infectious patient, the right thing to do is to keep that patient in the negative pressure containment room, and air infiltrates inside, not the other way around. So the outside is safe from this particular patient. So the pressure gradient rationale is always that the cleanest areas are kept at the highest pressure compared to the next clean area. General areas are lower pressure, dirty areas are negative pressure. So air comes into the cleanest areas and then goes out through the dirty areas. So if you look at typical operation theater suite, you'll find that the operation theater is at the highest pressure. Of course, the store which dispenses the instruments and all that is kept at a still higher pressure, because all sterile instruments would be here. Then you've got the scrub where they wash their hands, which is at a low pressure. Then you've got the clean corridor, which is, you can see, at a lower pressure compared to the operation theater. Then you've got a gray corridor. where there is a movement of, people and things like that. So this is the gray corridor, even lower pressure. The lounge, the doctor's room, and the toilets are kept at a negative pressure. So you know which way the contamination should be moving. If you look at a overall picture in terms of pressure gradients in a hospital, you'll have to bear in mind that the hospital has got various zones. You've got the outer zone, which is comprising of outpatient departments, the lobby, main entry, emergency department, emergency entry, admission, administration, and office. Then we have got the second zone, which is comprised of pharmacy, radiology, laboratory, main lobby, and then we have got the inner zone. These are physical areas which provide nursing and supportive care under medical supervision, are generally classified as restricted entry areas but may be accessible to patients' attendants. Then we have got the deep zone. Deep zones, these are physical areas which have got strict infection control protocols for activities such as medical procedures, surgical procedures, childbirth, postpartum care, neonatal care, critical care, isolation, etc. Such areas have restricted entry. And then, of course, there is the service area, physical areas which offer back end support for various day to day activities. And coming to the pressure gradients, you can find that the deep zone is at the highest pressure. These are the most critical areas. Then you've got the inner zones, which are slightly lower pressure. Second zone, the outer zone, and the service zone. So this is how the pressure gradient is, distributed all over the hospital. Now we come to another very important aspect, that is humidity. We started off with humidity, saying how important it is in terms of our respiratory system, and now we'll go to elaborate on this. Uh, the optimum relative humidity ranges for minimizing adverse health effects. There is this sterling chart from ASHRAE. You can see the growth of various pathogens at various RH levels, starting from 10%, 20%, right up to 100%. Uh, the thicker the line, it means more growth. Thinner the line means less growth. So you can see bacteria, uh, the whole spectrum of them would have very high growth at very low RH. This decreases towards 40%. Again, after 60%, it increases again. So if you look at all these various pathogens, bacteria, viruses, fungi, mites, respiratory infections, chemical interactions, ozone production, all these, the optimum RH is 40 to 60%. So in this is considered to be the best RH to have in a healthcare facility, especially in all the critical areas, such as your ICUs, isolation rooms, then operation theaters. You should definitely have control between 40 to 60% RH. Then we'll look at something about the growth of fungi as per temperature and RH. Here is a chart which is again taken from ASHRAE. Uh, See, we have got various uh, fungi. Let's start with Aspergillus rubor. You have to look at what is the growth of these at above 80% RH. You can see, in this particular chart, we will look at what is happening at the outlet of the cooling coil. At the outlet of the cooling coil, you expect the temperature to be, say, around 12 degrees centigrades and 85% RH. So if you look at this chart, the growth is 1 mm per day. So just try to visualize what happens in 100 days. 1 mm grows to 100 mm, correct? That's a huge amount of growth. So anything which is having high RH, especially after the cooling coils, you find high RH. You'll find the growth is going to be very substantial. Similarly, if you take the case of Penicillium cyclopium, here For 12 degrees centigrades, 85% RH, you find that the growth is zero point 0.1 mm per day. But that's not a big consolation. In 100 days, it becomes 10 mm. If you look at Stachybotrys chatalum, which is quite a severe fungi, here at 95%, it's not 85%, 95%. At 95%, you'll find again the growth is zero point 0.1 mm per day. Uh, say 100 days, it becomes 10 mm. So just imagine a few spores land up in your duct, which is at a very high RH. You know that after a few months or matter of year, you'll find that the whole inside of your duct will be covered with fungi for sure, of all these various categories: Aspergillus ruber, Penicillium cyclopeum. These are only three of them. There are a lot many. These are mostly associated with air conditioning systems. So if you look at the parts of air handling unit systems vulnerable to fungi, you look at this. Uh, you've got the return air, which is say at 23 degrees centigrades, 55% RH. You've got the mixed box. You've got the pre-filters, cooling coils, blower, second stage filters. So uh, what's going to happen? See, the return air duct is at 55% RH, so it's not vulnerable. The pre-filters are also at 55 to 60% RH, having mixed with the treated fresh air or fresh air. It's going to be in this range, not vulnerable. But drain pan has got liquid water, so it's highly vulnerable. You'll always find that there's going to be some amount of fungus out there. Then we have got the post cooling coil. You get 12 degrees centigrades, 95% RH, very vulnerable. These portions of the air handling unit. And then post filters, again in the range of 95% RH, very vulnerable. Supply ducts are going to be very vulnerable to growth of fungi. So here what we are trying to say is, do what you may, there's going to be a likelihood of fungus post the cooling coil all over the air conditioning system, right up to the supplier duct. Filter media will, having said that, I will also talk of how to avoid this fungus or restrict this fungus. So, growth of fungus on filters, filter media with inert properties like fibrous glass paper and polyester felt are chosen to discourage fungal growth. Failure to regularly replace or clean filters can lead to accumulation of debris and fungi, creating food source for fungus to thrive. If you look at this filter media, you'll always find that fungus is growing on that. And excessive surface relative humidity, as we have seen, more than 85%, can promote mold growth on filter media, particularly when the material remains damp for extended periods. Mold growth becomes even more probable when the surface RH surpasses 85 to 90%, especially if the media becomes saturated with water droplets. Water droplets is the worst thing that can happen. If you've got water carryover, you have the filters, totally wet, and fungus is going to happen for sure. So when thick formation of dust accumulates in ducts, high humidity levels can lead to mold growth. Delayed mold problems can occur if filtration is effective and water droplets are eliminated, but duct surface still traps dust and humidity. See, basically, you'll have to know that this duct, if it is very, very smooth from inside, the chance of uh, fungus, I mean, dust accumulation, and consequently the fungus on that is going to be very, very low. So if you have a duct which is, having rough surfaces and things like that, fungus, it encourages the growth of fungus. This is the reason the duct surfaces should be smooth and non-porous to prevent the accumulation of dust and humidity in the ductwork downward of the cooling coils. So reducing RH below 80%, we said that especially if your RH is more than 80%, you have more of fungal problems. So we should look at how to make this happen. So how you do is basically you have got the dehumidified air calculations, and you've got, in addition to that, you should have certain amount of bypass. So the more the bypass, it means, part of the return air which is at lower RH mixes with this, very humid, very high relative humidity air, and decreases the relative humidity post this cooling coil. So if you can see, when there is no bypass, we'll just look at what is happening at the second stage of filters, that is at 7. So when there is no bypass, we find that it is 89% RH in this particular example. Now we find that the dehumidified air